I'm a clinician, so physician, not a physicist at all. So if I speak really, let's say, inappropriate or really incorrect terms or facts about the physical background of OCT, please forgive me. But if you ask me medical things, I try to ask you as correctly as I can. So I would like to talk about the application of optical coherence tomography in my let's say specialized profession in cardiology, which is the coronary interventions. So this is a therapeutic approach, which I presume that you heard already, maybe, or from your studies, or maybe from your relatives or friends, that this is the coronary artery, at least lumen, with the cast, what the contrast dye feels by means of a catheter, and so this will enlighten those alterations, those obstructions, those stenosis, as we call it, inside the coronary arteries, which is responsible for the patient's illness or acute illness. Maybe this could be a complete obstruction that is the substrate of myocardial infarction. I still use my old.
Nem látsz a kamerában, hogy annyira messze, hogy a másik oldalról kényelmesebben már.
Maradnék itt, jó? But these interventions really solve the problems, or the chronic complaints of this chest pain, of this coronary heart disease, as we call it, or the acute obstruction, the myocardial infarction. And this is such a breakthrough technology. We've been doing it, the pioneers used to do it already 30 years ago. But the technology so rapidly progresses and improves that now they say that this is really maybe the most frequent intervention or operation in the world. It means that maybe 5 billion per year, and it's increasing exponentially year by year. So this intervention, this coronary intervention, in the end you will see, if you come to our lab this afternoon, you will see 1 or 2 patients. Most likely will result OCT for the diagnosis, what's going on inside the artery. I will show you the details now. Or really the procedure, the placement, the dilatation of this obstruction of the epicardial coronary artery, and the process of the implantation and the deployment of the so-called coronary stent, which really this is a metallic prosthesis which remains there for all the rest of the life of the patients. But it's a long-lasting and it's a very safe procedure and a long-lasting solution. So I told you angiography. So this is the process where inside the catheter a contrast dye is injected selectively to the proximal part of the coronary artery. In this picture, this is the proximal. This is the left coronary artery, and actually this is something like an example which shows you maybe really most of the vast majority of all different kinds of let's say possible possibly visible alterations on angiography, which corresponds to a certain pathology. And the pathology, the real cause of the disease that really lies beneath in the coronary wall. So by angiography, this contrast dye feels only the lumen, the inside lumen of the remaining coronary artery, and outside the X-ray, what we use, it really passes through without any attenuation the coronary artery wall. So we don't know anything about the underlying pathology. But in this case, different kinds of alterations we can observe already on angio. That this is a critical stenosis of the so-called circumflex artery. This is responsible for we call it effort angina symptoms of the patients, where when somebody tries to exert himself, but he has to stop because of this compressive pain in his chest. But this one, and it's really very seldom we see, but this is a large thrombus that could be responsible for ectopyrocardial infarction. But in this case, it didn't cause an abrupt and complete closure of the artery, since the distal part of the circumflex artery still fills up with contrast. But this is something in acute or subacute phase of a plaque rupture, which complicates the long-lasting ischemic heart disease of that particular patient. And this alterations of the arterial wall, this plaque formation, that starts already in our adolescence. And as time goes, when we are in our 50s or 60s, and the more triggering factors, the more comorbidities like diabetes, mellitus, hypertension, smoking, the more likely that all these kinds of lumen, this wall abnormalities develop throughout, and this is something, let's say, a tragic feature of all of us, of our nature, that the proximal parts are really the most affected by this disease. So if there is a plaque that will disrupt suddenly and cause a complete obstruction more proximally, the larger the infarction what we get, and the more likelihood that sudden cardiac death or a large infarction will develop. So this kind of irregularities, this is something very usual. The older and the sicker patients who we examine, there is always a large incidence of this kind of disease what we can see. So this is I guess I don't show other pictures of our cath lab. So this is the X-ray machine, this is the X-ray generator, and this is the fluoroscopic how do you call it? We call it image intensifier. So this is the X-ray, where the X-ray lens. I'm really not good in physics, sorry for that. But whoever will join to the cath lab this afternoon, you are, I'm sure you are perfect in identifying all the different parts of the X-ray machine itself. So you will instantly know what we are doing with this, all the basic equipments. So optical coherence tomography, this is something new, maybe a third generation what we use already, but the very beginning of this whole, let's say, new change in paradigm was the introduction in the early 90s of intravascular ultrasound catheter. So beforehand, only the pathologists who examined only the already deceased patients really realized the problem that all the things really it's in the arterial wall. So the new the first possibility to examine it in the human living body was this intravascular was the introduction of intravascular ultrasound catheter. And of course we can realize that the major breakthrough is that in the early 90s that they were successful to miniaturize this intravascular probe. Before the 90s, they used to be large transducers like this fist or something. And the coronary arteries, in which we are interested, they could be as small as 2 millimeters inside, or maybe even less. So this catheter now it's just less than 1 millimeter in diameter, and it doesn't really harm. It can, if we are not, let's say, delicate, we are not cautious enough. It still can harm the inside, very fragile, intimal layers of the coronary artery. But now it's really something which is quite frequently done in the cath labs. This intravascular catheter is really still expensive. It's around 500 or 600 euros, but sometimes it really helps and it's still used. So actually, this is the pathological cross section, the basic structure of the coronary artery. So this is the inside lumen, a very tiny endothelial layer is facing the lumen where the blood flows, and this intima, when a patient, when a normal human body is not really affected by this disease, it should be only 500 or 50 or 100 microns in the intima, but it can grow as big as this. There is no scale in this particular picture, but it can be as thick as 1 or 2 or maybe 3 millimeters in thickness. And the outer layer, this media, this is the muscle, the smooth muscle layers. They tend to be let's say constant during our lives. It's only it's 100 microns or so. The adventitia, this is this bright shadows, bright structure in the echo image that reflects the ultrasound. That is something let's say that holds the artery's own little supplying small arteries, and this is fat tissue, but we are not that interested in that. So OCT, this is where we stand now. So you can see that of course it's not a real 3D image what the OCT with its lens pulled back from the distal to the proximal part of the coronary artery, and this is the guiding catheter already. So this is originally not a real three-dimensional information what it provides, but if we couple it with the angio, if we do it simultaneously in 2 different angles, we call it projections, then a real three-dimensional lumen, and also some wall information what we can subtract from this OCT examination. So, but this is still not in commercial use, but they are just about to introduce this. So OCT, as you already know, has been used in the since until 2004, the image wire was okay, that was very thin, but it needed and still it needs to get rid of the blood, since the blood contains erythrocytes, small, very fast flowing, little particles, which attenuates and reflects back the light what the OCT is really a major let's say working mechanism. But this image wire before 2004, that was the only available technology that needed to have the coronary artery completely occluded to get rid of the erythrocytes. So it was really not let's say applicable in the everyday use, because if you occlude the coronary artery, you can create a myocardial infarction really in an unwanted manner. But this new generation, maybe at first it was time domain, and then the second generation is the Fourier domain or frequency spectra. As many vendors, as many different names as they call it, but optical frequency domain. But this is really the same basic mechanism how they work. From the 2008 now it is available, and also in our cath lab the last 4 years we've been using it quite often. For the clinical practice we cannot, since it's still expensive, even more than the intravascular ultrasound catheter. It's only, let's say, 30 or 40 cases per year, but in clinical studies where different kinds of let's say pharmacological interventions are intended to decrease this plaque growth, as many as 100 or maybe sometimes 200 patients will be examined for a clinical clinical study, where the pharmacology big company provide the catheter free of charge, of course. So you know it much better how this frequency domain optical coherence tomography works basically. But the real difference between the intravascular and ultrasound is really the resolution what we get. So it's really 1/10 of the resolution of the IVUS catheter, which in the last decade, which we've been already very much satisfied, and we are really happy to see all the little details what we didn't use to be able to identify on angiography. The frame rate, because the blood still has to be disclosed throughout this pullback of the OCT catheter completely. So we use flushing with contrast agent, and this flush sometimes it's 15 or 30 millimeters of contrast throughout. Let's say it used to take 10 or 12 seconds. That's too much for a patient. So the frame rate and the resulting pullback speed, if it at least 20 millimeter per second, or sometimes now the newest machines, they are able to do it 100 millimeters per second, so 10 centimeter per second, and that required only 2 seconds of filling up the coronary artery with contrast agent. So that is really, let's say, suitable for the everyday use. So you will see it in the cath lab, but this is a good demonstration video how we connect the catheter. This is the tiny catheter which goes inside the coronary artery, and this is the distal tip. This is the optical lens, and this is with the new catheter which we've been using in the last year or so. It's only about 2 centimeters away from the very distal tip, because so more distally we can track down the optical lens. And this is a wire on which we reel these catheters, and this wire goes down to the very distal part of the coronary artery, and this will track down any kind of catheter what we use. So you will see that first the guiding catheter gets into the place in the proximal part of the coronary artery, then this very tiny wire. Can you see it? I don't know. And we can reel down any device, any kind of little instrument what we use for this percutaneous coronary intervention. And for the OCT, this is of course the same. And this is how we connect it to the motor drive unit, which will spin this optical cable with a very large rotation speed. This is around, I really don't know it by heart, but this is around 2,000 frame rate per minute. The spinning rate. And there is a plastic tube which covers this fiber optic little cable, so there is no heat transmitted to the blood or to the epicardial wall. At least we believe that there is no thermal any kind of side effect of this examination of what we do. So now this is really these years a fast and safe imaging procedure, and actually this is already I mentioned it in the last couple of slides. So this is then an animation with the erythrocytes, with the wire already placed to this particular stenosis, this lesion, what we are interested in to get the details on. So this is this plaque full of atheroma or any kind of other tissue. So this is a loop. You can see that the procedure is as fast as this. The resolution. So this excellent resolution, that is the 15 or maybe 10 micrometers. That enables really this very high resolution. That enables to identify maybe already the individual cells. This atherosclerotic lesion is much more prone to rupture, much more susceptible to rupture when there are so-called macrophages in this luminal wall. And these macrophages, this is a certain type of white blood cells. Those are as big as 10 micrometers or 12 micrometers, and they can be identified one by one. And they are summing up all of them. This is really something what intensive research going on. What is the clinical information what they had. So you can see that this is on this cross-sectional image that the transverse resolution is also very good. You know, you can let's say describe to yourself this all these pixels and all these things what was listed on this this is an examination. What we did actually, this was the very first of us 4 years ago already in our own cath lab. So this is the wire. This is an echo. We call it radio pack. Radio pack. So the wire is more, let's say, radiolucent in the proximal part, and this is the distal tip of the osteotic catheter, and then the optical lens is withdrawn during this injection of the contrast in this left anterior descending artery, and the image what we obtain is this. So this is the real real-time pullback speed and this run, as we call it, pullback run with 20 milliliters per second speed in this particular artery. And of course, later on, we can stop this pullback whenever we wish, and we will practice it in the lab this afternoon. And cross-section by cross-section, we have to analyze all the little things what could be of interest for us. So this is the so-called animal longitudinal view. This is the cross-sectional view, and this old IBUS machine used to call it B mode. This is let's say, so we try to identify all the alterations correctly in our practice, but there are still many potential artifacts which really limits our precision. And for example, this particular tangential signal dropout is really something very important because so-called very dangerous thin cap fibroateroma, it can mimic the presence of this atherosclerotic region, and in reality it is not there. It is already the appearance because of this tangential signal dropout. This might be something so obvious that even with your future work you are not going to be able to avoid it or to overcome this. But maybe some other potential limitation and artifacts. What we really don't understand how they are generated, but you do. But it really let's say impairs our daily decision making in the cath lab. So these are the connecting points what we already know about, and you will see you will have the solution for this. So this is the almost healthy vessel with a very thin layer of the intima and very thin of the media and the adventitia. Their appearance is much different than that of the intravascular ultrasound images. The clinical experience has been growing in the last decade or so, and already with the second generation user-friendly or patient-friendly machines in the last 5 or 6 years, and already in 2012 the experts summed up all the basic things what we have to know about it for the clinicians. So for these and for the clinical practice, there are certain categorizations. So when there is a clear-cut indication for there is a so-called level 1 category. But the OCT only received when there is a contraindication that which intervention or diagnostic method used to be done in the routine practice but turned out to be not useful, that those procedures they shift to the so-called level 3, which means a contraindicated procedure anymore. So it used to be an accepted methodology, but OCT is still a 2B. That means that it is indicated sometimes if the particular physician is interested or expects some benefits of the OCT examination. 2A level is when there is a general agreement that a good physician who is skilled in this particular thing will provide benefit to the patient. OCT is still 2B, but within this 2B general indication there are some other kinds of approach which is so-called evidence level, in which there are certain proofs already available that what we can gain with the information of the OCT. And this is the atherosclerosis, the estimation of atherosclerosis in general, and the thrombus, that means the blood clot. That is really discernible very easily, and we can even judge whether it's a fresh thrombus inside the coronary artery which can still close an obstruction, an occlusion of the artery, or it's an old one. So it's really, these thrombi are sometimes very small, but they can be very dangerous. These can be identifiable very easily with the OCT. The distinction between the fibrous and the lipid pool is not that easy, and sometimes they call the necrotic core, which is different kinds of animal. Those are really something not that easy. So this lipid core, where full of fatty tissue, the artery wall inside, it's not easily identifiable. But it's really important when a lipid pool, which is a fragile something, which when in most of the patients, most of the lesions, those are covered with a so-called thick fibrous cap. This is a, let's say, protective layer which prevents the rupture itself. But when it is less than 65 micrometer, this fibrous cap is maybe sometimes 150 micrometers thick. When it goes down to less than 65 micrometers, at least the pathologists they identify that these could be, in the longer term, these could be so-called the leading feature of the so-called Vanderbilt plaque. So the estimation, the complete measurement of a stenosis, sometimes it's almost impossible with the traditional angiography. So this is left main. This is the very proximal part of the left coronary artery. Whether there is at least 50% when there is an indication for doing something, a real so-called real exploration for the patient. If there is at least 50% lesion in this very focal segment of the left main, just proximal to the bifurcation, it is really dubious on this angiography. But if we examine this particular patient with the OCT, you can see that this particular lesion is almost let's say nothing. We can really measure the area really precisely, and we can really decide whether this patient needs to get treated or not. But in the circumflexation, the osteomotor circumflexation, which doesn't appear like stenotic on the angiography, this is very stenotic. So for diagnosis making, it's already a very useful tool. When on angiography we cannot really let's say establish the correct extent of the coronary stenosis. The other major territory, and it's really something I'm already at least halfway through my lecture, so please don't give up. I'll finish it hopefully very soon. So stenting, that is the other very important area where we don't know how useful it is going to be, but this particular let's say alteration right after stenting, sometimes it can be really hidden. It sometimes can be undetected, remained undetected on angiography. You can see that the small metallic little struts, cross section of the elements of these stents, they are not lying. They are not attached to the lumen, and those could be really the spots where, if there is a slow flow in the coronary artery, maybe during the sleeping of the patient, or any other, or there is a prothrombotic status of the patient. So this is really very dangerous. And on OCT, if you perform OCT, and there are particular studies going on to establish the real diagnostic value of OCT compared to angiography alone, but this requires at least 2,000–3,000 patients to examine during the long term in a blinded fashion. So if to prove its clinical utility, so if the operator can see with the OCT but not on the angiography, he still has to is prohibited to intervene. He is not allowed to. So you can see that this is something very important issue. This is a small thrombi which remains in the artery wall. This is the plaque prolapse. So every kind of little details can be revealed if you perform OCT right after stenting. And it's quite a frequent alteration. So we don't know its knowledge. The impact of this knowledge we really don't know on practice as yet, but maybe 1 or 2 years and we will know. And actually this particular patient in this right coronary, he received 4 stents. So all the way down, this is at least a 15 centimeters long segment. All the way down, there is a metallic cage, which remains for the rest of the life of the patient. So maybe most parts they look okay, and all the parts they look okay on the angio, but there are some 1 or 2 millimeters which can be identified by the OCT, which can cause in the longer term the thrombotic occlusion of this vessel. So it was quite, just let's say, not only in vain, but maybe in right after the procedure the patient feels all right. But if this little alteration remains undetected and uncorrected during this procedure, this patient still will live in danger. for many decades on. So this is really something important. There are certain, of course, already, let's say, approaches how we should measure this the extent of the stent apposition, because we can only see the intimal leading trail, the intimal surface of this metallic strut. So also we don't know how much coverage is really needed in the long term. And I will show you one patient for today. He receives his stent a couple of years already, and some months ago we did the angiography, 3 or 4 months ago, and there was a certain borderline restenosis within his stent on angio. Today we really try to describe it correctly and what is the mechanism, because sometimes not the so-called neo-intimal hyperplasia which is responsible for this stenosis regrowth, but sometimes the stents, they are not strong enough, and maybe the outside forces in the long term they cause a so-called chronic recoil of the stent, and the interventional management is quite different for the two. So we can discriminate between these two mechanisms. Today I hopefully can show you a good example. Neoatherosclerosis is something different. That means that within this intimal hyperplasia, quite a thick layer, new atherosclerosis can develop. We were not aware of this quite nasty long-term, let's say, side effect of stenting. But since now there are many patients, 10, 20 years after having received a stent, we know, unfortunately, new atherosclerotic changes can develop inside this artery. So I think that this is what I wanted to tell you about general things about the coronary arteries and OCT. I put a very interesting case, but I guess that I will spare you some minutes for the questions or for getting some rest. So thank you for your attention.